Good evening and welcome back to the Canadian Concussion Centre's webinar series, which is sponsored by LIUNA, the Labor's International Union of North America. My name is Leslie Rattan, and I'm pleased to be moderating our webinar series, which was developed originally for individuals that had sustained concussions, were struggling with persistent symptoms, but also for caregivers and healthcare providers as well. If you've been with us before, you know that our sessions focus on various aspects of concussion. And we start with an expert speaker who will speak for about the first half. And then we open it up to your questions so you can get your questions answered this evening. And these sessions run every other week on Tuesday evening, live from 6 to 7 p.m. I'd like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we are meeting virtually, I'd like to take a moment to acknowledge the importance of the lands which we all call home, to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So back to the webinar series, just so you know, if you have missed any of our previous ones, you can go to the Canadian Concussion Centre's website, and all of our previous presentations are archived there. Also, just for this evening, if you do have any questions and answers, if you just move your cursor to the bottom of the screen, you'll see that there's a Q&A. If you have any questions for our speaker tonight, you can just enter them there. If you're having any issues with technology, you can enter those into the chat, and Christian will help you out. Just going to run a very short poll that we run every time we have one of these, just to get a sense of who we have in the audience. So I'll just give Christian a second to put that up. Perfect. And excuse me, for this evening's session, I'm really pleased to welcome back Dr. Eric Massicotte, who's going to be presenting whiplash and other spinal injuries in patients with concussions. And just a bit about Dr. Massicotte. He is a surgeon educator in Toronto, Canada. Since his faculty appointment with the University of Toronto in 2002, Dr. Massicotte has focused his academic neurosurgical career on spinal cord health and minimally invasive surgical procedures. Dr. Massicotte holds a Master of Science degree, and in 2017, as an associate professor for the University of Toronto, he completed a Master's of Business Administration degree to further advance his dual role as medical director for the back and neck program and the concussion program at Altum Health, a division of the University Health Network. The concussion program was an innovation that he started in collaboration with Dr. Charles Tatter. Throughout his time as a staff neurosurgeon within UHN, Dr. Massicotte has contributed to furthering research within his special interests, medical education, patient outcomes, and spinal stability. In collaboration with colleagues both nationally and internationally, Dr. Massicotte has been invited to lead numerous international lecture engagements, and he has over 70 publications in peer-reviewed articles to his name. So with that, I am going to turn it over to Dr. Massicotte.
Thank you, Leslie, for a lovely introduction, and once again for the opportunity to speak to this audience about what I consider a very interesting topic. So let's dive right into it. I've sort of changed the title of the talk to "What a Pain in the Neck." Let me begin by sort of some disclosures. I don't really have any conflict of interest or anything like that. I'm an associate professor at the university, as mentioned, staff neurosurgeon at University Health Network, and I'm the medical director for the back and neck program. So there's nothing that I'm going to say today that is in any way a conflict. What I'm hoping to do over the next, sort of 30 minutes with the presentation, and then hopefully with some questions afterwards, is really to review the topic of neck pain, and really trying to sort of explore and, sort of illustrate some of the different presentations and different causes of neck pain. and really kind of emphasize the point about collaboration between different health professionals who encounter neck pain, maybe not as a primary sort of diagnosis, but certainly as a secondary one, or as one that's, is often seen in conjunction with others. So the outline really is going to be looking at sources of etiologies for this, for neck pain, and then looking at the association between the two, and try to give kind of an overview of some of the presentations that I see as a neurosurgeon when it comes to radiculopathy or myelopathy, which are important to sort of tease out because they can be sort of thrown in there with someone with a concussion. And then, trying to sort of showcase some different examples of management, etc. So let's start off with the definition. And to this audience, I mean, this definition shouldn't be a surprise. It shouldn't be, I shouldn't be, shocking anyone with this. But the point to make in starting off with the definition is that the trauma does not necessarily have to go to the head directly. And so the trauma can be sometimes to the body or to other parts, and can result and translate into forces that are transmitted to the neck into the head. Obviously, the two are very closely tied to one another, so you have to keep that in mind. And when we're talking about a differential diagnosis for, say, headache, there are multiple causes and, sort of etiologies that you can look at. And I like these bubble diagrams because they sort of really illustrate kind of the state that we're in when we're trying to approach a topic like headaches. Because you've got all these different things that can percolate up, and depending on your exposure or your experience, some of these bubbles will be bigger and more prominent than others. Obviously, if you have a practice like, say, a neurologist who has a headaches practice, well, then you're probably not going to see some of these more common headaches, but you will see others. And so these bubbles will change in size for you depending on where you are. And obviously, as a patient, all these bubbles kind of illustrate the fact that sometimes it's very hard to navigate. So it's nice to have kind of an approach and say, okay, let's say you have a headache. Well, what do you do with that? How do you sort of approach it? How do you break it down? Now, I know some of you are thinking, well, wait a minute, isn't this guy supposed to be talking to us about neck pain? Why is he talking about headaches? Well, when it comes to headaches, we have a little bit more of a chartered sort of approach like this. But when it comes to neck pain, it's a little bit harder because the etiologies can sometimes be fluctuated. And here's an example of, sort of different patterns of pain when in fact, some of these would fall under neck pain. So depending on, when your patient comes in and they say, well, I have a headache, well, you have to kind of dive into this and get more information. Just like when somebody comes in and says, I have neck pain, and say, well, what exactly do you mean? Where is it? What is it brought on with? What is it better? All of these sort of follow-up questions become very, very important because that can sometimes give you some information or give you a better sense of, one, are we talking about the same thing? Are we talking about truly neck pain, or are we talking about headaches? And two, how are we going to sort of make some headway with regards to getting at the etiology? Understanding trigger points. These are obviously very important because they can help us in making a diagnosis and getting at the etiology or the source of this pain. So, source of pain, how do we tackle this? One approach would be to break it down into, say, anatomical or pathological or biomechanical sort of etiologies. And this can sometimes provide a certain amount of structure, but as you'll see in the next few slides, this is only a little bit of a beginning of a framework in something that is very complex and interconnected. So here's an example of some of the neural circuitry that we have. And, we're just giving you example here, taking the picture on the left, you can see an, illustration of the brain, and then you can see some of the pathways going down into the spinal cord. And these are connected with receptors, in this case, spindle cell receptors. And these really kind of get a sense of whether or not the muscle is under stretch or not. This becomes relevant because if the muscles are in spasm, that can be the source of a great deal of pain because it activates the circuitry. And one of the things to remember is that if you have someone with muscle tension in their neck, and they also happen to have a concussion, the two coexisting conditions can lead to a very difficult picture to sort out and to try to identify the true etiology. So we can try to, sort of simplify some of this circuitry and go to something more like this. But even this doesn't capture everything. And although, I'm using this example as a simple sort of diagram, and some people would look at this and say, well, that's pretty complicated because a lot of arrows are, going back and forth, and you've got dotted lines and everything else. But the point to make here is that these circuitry are very important. They interdigitate with one another and they have impact on one and the other. So trying to tackle the etiology is challenging, but also when it comes time to talk about how do you go about managing it, you can't try to tease out and say, okay, well, let's just focus on the neck pain, or let's just focus on the headache or the concussion symptoms. You have to kind of take it as a whole. And this is a general principle that really kind of serves us well when we're dealing with patients in trying to understand and provide a management strategies. And we can't just sort of isolate just one thing. And I'll come back to this a little bit later. This slide I've used for many, many years. And the reason I like it is because this is a anatomical specimen on the left, and on the right is an MRI, which is frequently used for high definition of the anatomy. But you can see the level of detail that we're able to generate from this. And in some cases, the level of detail provides us with more information than we know what to do with. So this is a normal sort of neck, a normal MRI, but this is on someone who insisted on having an MRI because they had lots of neck pain and lots of issues. But the imaging is completely within normal parameters for their age. Now, when we're taking a history, all clinicians need to be aware of some of these red flags, and these are really, they've been around for a number of years now, several decades, but they're important red flags because these sort of indicate that maybe there's something underlying that's, a little bit more ominous and needs to have further investigations. Won't go too much into that. So now if we sort of take a step back and we talk about clinical presentations, well, as a neurosurgeon, I will see and really, try to identify sort of patients with cervical radiculopathy or myelopathy, because these are the type of patients that respond very well to surgical intervention. Combinations of the two are obviously also an entity that we see in a fair high level of frequency. But the vast majority of people out there in the general population, and certainly individuals who've suffered with concussion, will have axial neck pain, which don't fall into the first three categories. But for the sake of completeness, and as a neurosurgeon, I have to go through this because I'd be remiss if I didn't cover this. So here's a typical clinical presentation of someone with a cervical radiculopathy. Radiculopathy means the nerve root is being irritated. This is an individual who presents with a herniated disc. Now, if you look at this picture here, the sagittal image, it looks pretty much like the other one, but in fact, there's a herniated disc here that bulges out and pinches the nerve as it comes out. So this individual has failed conservative management. He has this disc and it's having a significant impact on his activities of daily living. And so this individual was offered surgical intervention. The way I do this is an anterior cervical discectomy. This is an X-ray picture with what was done. You see the disc material here has been removed and the posterior aspect, which was compressing the nerve, has been completely resected and the nerve is now free. There's an allograft that's been put in place, and you can see that here is a little bit more dense compared to the native bone. And then there's a plate and screws been over top. This picture here is actually taking in the operation. You can see the plate, and these screws basically go into the body above and below and hold this allograft piece of bone in place until there's an eventual fusion. Now, the most important part is not the pictures and the surgery or the x-rays, but is really the outcome measures. And for this individual, he was a golfer. So his big question to me on the first visit post-op was, when can I go back to golfing? And this picture is a lovely picture taken in the fall at a private golf course in Ottawa, which was his sort of stomping ground. So he was quite happy to return back to this sort of lifestyle, being able to swing a club and enjoy life. This individual presents with a little bit more trouble, and his issue is not compression of the nerve, but actually compression of the spinal cord. So in that case, it's called a myelopathy. The spinal cord is not working well. And this can present with not just neck pain, but it can also present with issues of fine motor skills, numbness, weakness, difficulty with walking, steadiness on your feet, and problems controlling your bowel or bladder. So very significant amount of dysfunction because the spinal cord is unhappy. So what we need to do here is really to decompress. You see the spinal cord here going down to the spinal canal. It's supposed to look more like this, where there's white stuff in the front and in the back of the cord. This white stuff is actually cerebrospinal fluid. But in this case here, it's being compressed because of bone spurs and degeneration at each of these levels. So what we have to do, again, I'm showing you an intraoperative picture partway through the surgery where there's removal of the back part of the bone in order to make the spinal canal bigger. But then, of course, if we do this at multiple levels, in this case, 7 different levels, I don't want his neck to fall apart afterwards. So I have to do what's called an instrumented fusion, and that is to put in these screws and then to fuse everything together. The success rate for this, and we define success as the ability to prevent further neurological deterioration, is very good with this. In fact, it's somewhere in the neighborhood of about 90 to 95%. Now, some of you may be wondering, like, how does he know it's 90 to 95%? Well, good question. The reason we know is because we've studied it, not we've looked at the literature and see what other people have done. Our sort of outcomes, our sort of metrics, we've actually are one of the leading centers in North America on this topic. And it is very important because, there tends to be a very nihilistic approach to some of these patients. This can lead to permanent neurological compromise, leaving patients not only with weakness and numbness, but, profound impact on their quality of life with being bedbound for the rest of their days. So this is one of those surgical successes that needs to be identified earlier rather than later in order to have better outcomes. So now let's come to the majority of people with neck pain. And what do we mean by conservative treatment? Well, conservative treatment here, if we look and synthesize a lot of the literature that's out there, is that it involves exercise. It involves recruiting the muscles in order to make sure that they're nice and strong and working on people's posture. This has been particularly relevant, and some of you will appreciate this if you have young, sort of young kids, teenage or preteen. They spend all their time on their tablet and they've got this terrible posture where they're all curled up, etc. And they spend hours and hours on that. So posture has been sort of profoundly affected, and we're starting to see some of the outcomes of that. Whereas people are presenting a little bit younger now with more issues with their degenerated sort of spine, particularly in the neck. So the strategy with therapy here is to focus on involving exercise, doing some education to reassure people that they're not going to damage themselves if they focus on core strengthening, and making sure that their posture is improved. Now, of course, this all sounds very easy, but in fact, it's quite difficult and challenging because what it involves is trying to get people to change their habits. So instead of just sort of sitting on the couch all curled up looking at your iPad or your phone, you have to, sort of get up and do some exercise and weave that into your everyday routine. These pictures are here really to illustrate a point that when we look at anatomical sort of illustrations, etc., you see that the bulk of the tissue, this is a cross section through the neck on the right side, and this is sort of an illustrated sort of side view of the neck. But the thing that should strike you when you're looking at all of this is that We've been focusing on the central part here with the nerves and the spinal cord, and obviously these are important structures. But when you take a zoom, if you zoom out and you look at the big picture and you look at an axial cut, you notice that the bulk of the tissue, the majority of the tissue, is actually this red stuff, and those are muscles. And so a strategy that involves strengthening those muscles to work on your posture and to provide more support means that you can offload some of the stress that are being put on the bones and ligaments and causing more wear and tear and degeneration, and have some more support from the muscles. The other thing that we're finding out is that as you have good muscles, you can see better blood flow, better regulation of your blood flow. So things like inflammation and, sort of irritation of that can be sort of better control if, again, your muscles are in good condition and have good tone and nice strength. This is in part where, why when people come to me and they say, oh, I've got this brace and I love it because when I wear my brace, my neck doesn't hurt. That goes against everything that I've been saying, because what that does is it basically conditions your muscles to be lazy, to be deconditioned. And this results in a cycle of bad posture, depending on the brace, muscles deconditioning, having more pain, getting you into more and more trouble. The reverse is what we're shooting for. The reverse, where you have muscles that are being exercised, recruited, nice in tone, with good posture. This is the sort of environment that you want to find yourself in, because then you'll be able to tolerate more activity. And with more activity, the muscles will get engaged, continue to be in good condition, and you'll see more sort of better quality of life. So getting close to the end here, the approach to concussion management, and some of you may have seen some of the other presentation, really there's a focus on having sort of a multidisciplinary approach. And the multidisciplinary approach is really to sort of capitalize on everybody's, sort of strengths. So if you have someone that's mostly, psychological issues or issues of mental health, etc., then, obviously having an expert like a psychologist or neuropsychologists sort of help you with those things makes sense. The physical and the more sensory stuff, then having a physiotherapist work with you. And if, some of your symptoms are dizziness or neck pain, sometimes working with a kinesiologist can help you to sort of understand what activities you should be engaging in and how to recruit those muscles and help you get into that positive cycle, etc. The cognitive stuff, as when it comes to some of the symptoms that you have with concussions, occupational therapists play a big role. So all of these spheres kind of overlap, but there's some degree of areas where one expert will play a little bit better. So if you're looking for, the best kind of treatment group is one that offers multi-modalities of treatment with different specialists, with different areas. And so this will allow you to, kind of migrate in the areas where you need it the most. So getting close to the end now, but the take-home message, really what I wanted to, get the point across for you guys tonight is neck pain etiologies can be varied. And it shouldn't be looked at as just, well, it's just your neck, so it's got to be just one thing, because there's multiple different tissues at play. There's some different pathologies that can be sort of activated at the same time, and the biomechanics play a role. So all of these kind of intertwine together, but a focus on muscle strengthening and posture, even if you have a patient with a radiculopathy, or even if you have a patient with a myelopathy, still having a focus on muscle strengthening and posture will help them set up for success down the road. If they are going to go for surgery anyway, getting them into a muscle strengthening program or posture training will help them be in better shape and therefore tolerate the surgery better. And then certainly following the surgery, this will play a big role because they will need to focus on strengthening the muscles in order to get the maximum function out of it. And that is all I had prepared for tonight. I think we're right almost close to the 6:30 mark, so I'm happy to stop here and turn it over to our moderator to handle the questions if there are any.
Yeah, that's great. Thank you so much, Dr. Massicotte. That was excellent. So just a reminder to those of you in the audience, if you do have any questions, just put those into the Q&A. Looks like we do have a couple here. We have someone saying that they've had several concussions. 4 have been in motor vehicle collisions with whiplash and hitting their head getting into the car. But I also have a pinched nerve, C4 to T2, because of scoliosis, and I have constant neck pain. How do I know if this pain is still from the whiplash and concussions versus the pinched nerve?
So when it comes to pinched nerve, as a surgeon, what I rely on the most is an MRI, because structurally, if I can identify, where the nerve is supposed to be, and I see a herniated disc or, a bone spur or something like that, I find that is really kind of the best way to sort of rule that out. If you have scoliosis, then there's going to be a little extra curve, so the images are more challenging to interpret. But definitely, sort of the structural component of this, of pinched nerves. Now, you have to be careful because sometimes the nerves are irritated and it feels like a radiculopathy, but it's not coming from a pinched nerve. It's coming from an inflamed nerve or a nerve that's irritated due to inflammation, etc. And so it feels like a pinched nerve, but it may not be the etiology that we're looking at. And so as a surgeon, if the nerves are inflamed, me doing surgery on these nerves is actually a really bad idea, because that results in causing scar tissue and getting you down a pathway of making things worse. So not only is there the risk with the surgery, but there's also the very likelihood of not helping. So that's why the interpretation of MRI needs to be done by someone who operates, someone who actually does surgery. Because the other encounter that we see very frequently is that you'll get a radiologist report. And patients have access to their files now, so they can look at their reports and they can read. And the radiologists who really don't assess you, don't examine you, so they don't really have a clinical picture to go by, just look at the pictures and they say, well, there's maybe some mild, moderate, or severe stenosis here, and there's maybe a mild, moderate stenosis there, and maybe some pinched nerves here, and maybe. At the end of the day, what you need to do if you're going to, be considered for surgery is you need to be assessed by someone who actually does surgery to review the images and have a look at you and see if there's a correlation, see if it actually fits the picture.
Right.
The other sort of tool that I sometimes use for determining whether or not surgery or pinched nerve is really the etiology is selective nerve root blocks. So this is where a someone with using X-rays will place a needle next to the nerve that we think is being compressed or pinched, and we'll put in some freezing and try to see if they can impact the overall symptoms that you're experiencing. So I think these are sort of 2 tools that I use to determine whether or not you're a good surgical candidate. And then, if that's the case, then you have a conversation about, what kind of surgery and et cetera can be offered.
Right. Okay, that's great. Thank you. Our next question, I've had several concussions. Oh, sorry, I'm reading the same one over again. I have daily headaches, 6 years post-concussion, have a history of whiplash, but my neck doesn't usually hurt. But if any practitioner even gently stretches my neck, it goes into spasm. Could the neck be causing the headaches, and how do I get it treated?
So this actually brings up a really good point. Cervical manipulations are not really advised. And part of this is because, your spine has a number of different joints at each of the levels. So a number of different joints, and at each level, we're talking about 3 different joints, 2 facets and 1 disc. And so someone going in there and actually kind of manipulating those and twisting things around is not really advisable. And, in some cases, as you sort of, observe in your case, when somebody starts to pull on your neck, that actually causes the muscles to go into muscle spasm. And the muscle spasm can be quite debilitating. People think, oh yeah, it's like kind of like a Charlie horse, and the muscle goes into spasm for a few seconds and then it settles down. No. This muscle spasm can be quite severe and quite debilitating and have an impact. And because the muscles attach to the back of your head all the way down to your sacrum, and if you have muscle spasm in one area, it can stretch and spread to another. This area can sometimes lead to headaches as well. So it's not as clear cut as, oh, you just have muscle spasm in your back. that can't be associated with headaches. They can be. And so trying to, get a provider that'll be able to tease some of these things out and then help you with the muscle spasm and, getting you on to the right type of exercise.
Mhm. Excellent. Thank you. On with regard to exercise, what exercise is useful when the right side of the neck is always tight? Sounds like this has been since a childhood concussion in a school playground.
So, as a neurosurgeon, my focus is identifying surgical patients and making sure that, those individuals I can help. When it comes to sort of understanding how to recruit the muscles, what type of exercises you need, etc., this is where, going to see the right type of physiotherapist, someone who understands, what each of the muscles does. And really the idea is that if you work with someone who can teach you, here's what we're doing, and you can understand what you're doing with each exercise, which muscles are you recruiting. And the body is set up in such a way that everything's in balance, right? So if you work, for example, the best example I can give you is if you work on your bicep, but you don't work on your tricep, well, then you have an unbalanced situation, and that can put some extra stress on your elbow, and you can end up wearing your elbow a little bit faster than you should. So the idea with the right type of physiotherapist who understands their role as someone who will teach you how to exercise, is someone who will show you how these muscles come into play, how you can recruit them, how you can build them up. And then the idea is that these strengthening exercises, it's not going to happen overnight. It's not going to be, well, I've had, 2 weeks of treatment. Why aren't I better? It's like, no, no, no. You're looking at, this is like training for a marathon. You're looking at building up the tone and doing a little bit by little bit. It's, I tell my patients, it's better for you to do 5 minutes, 5 times a day than doing, a 2-hour workout in the morning, but then not being able to move for 2, 3 days. Right? The latter situation is not the one where you're going to build the tone and the endurance and move forward. If you do a little bit at a time, you recruit the muscles, you get it to be nice and strong, but then you give it some time to relax, recover, and not always feel like it's being, bombarded and assaulted and completely flared up, then you're going to build some tone and you're going to build some strength. And so that's more successful strategy for someone.
Okay, great. Thank you. And yeah, it sounds like there's lots of interest in this. Daphne's asking what exercises can I do to strengthen my neck? So it sounds like seeing a physiotherapist would be a good idea.
That's the right way to go. Correct.
Okay. I've seen headache doctors for my headaches, but they focus on giving me medications. Whom do I see to determine if there is some neck dysfunction?
Right. So, I mean, the function of your neck is to hold your head up and to move about. So, if you have neck dysfunction, and that can take on many different forms, right? It can be just every time you move your neck, there's pain, then your neck is not accomplishing its function. My advice for this person would really be to go and see a physiotherapist and someone who can sort of say, okay, well, let's look at those neck muscles and let's see what you can do. Look at your range of motion, look at your overall functionality, and say, well, here's some exercise. So not just sort of identify whether or not you have neck dysfunction, because if you have neck pain, then I guess, you qualify as having neck dysfunction. It's moving on to the next stage now about treatment. How do you go about making that better? And again, focusing on the exercise.
Okay, great. Thank you. Lori is asking, what do you do if someone has CTE? That's not the CTE I was thinking.
No,
Cerebellar tonsillar ectopia or ectopia.
So if you have a sort of a congenital sort of anomaly, where the part of your cerebellum, the bottom part, the tonsils, is actually being pushed down through the foramen magnum, there's a series of different symptoms that can develop from that. But the recommendations that I'm making with regards to the neck strengthening and the core strengthening of the muscles, etc., can still apply to someone like you. Because the idea behind that is if you're doing the work yourself, you will limit and you will sort of work within your range of comfort. So when you're working with a good physiotherapist, they will assess you and they will say, okay, show me what you can do. They'll do their assessment. They'll see what your range is. They'll see where your comfort is. And then they'll get an assessment or a sense of where your muscles are at. And then they'll give you some exercises, focusing on extension, focusing on flexion, and what you're comfortable with and where you can build up from there. The beauty of doing active strengthening is that you're doing the work and you will have a self-protection mechanism. You will work within your comfort zone. And, you have to make a distinction between doing something to hurt yourself and working out the muscles and having stiff muscles and sore muscles after you've had a good workout. So there's good pain, and then there's pain where, you're doing something and it's aggravating. So working with the right, sort of provider here can make a big difference, because they'll teach you what you're supposed to do and help you navigate forward.
Great. Thanks so much. Lily is saying her husband was involved in a motor vehicle accident about 8 months ago, did have whiplash. All neck and head MRIs sounds like they were normal. However, he still complains of neck and reduced complaints of maybe neck pain and reduced neck range of motion. Also, sometimes when he's working, he feels that his right arm is very fatigued and painful and at times numb. Also, some weakness in the right arm. What kind of tests should be done next in order to find out why he's experiencing the weakness, numbness, and pain?
Yeah. So one of the things that we have to be careful of is not to keep chasing sort of answers, and associated with that is chasing that sort of silver bullet, that magic solution. It is, I will sometimes see patients where their MRIs have very little degeneration. There's no evidence of pinched nerves or anything like that. And that's what it sounds like in this story, that Lily's husband is, doesn't really have a structural abnormality because it's been cleared. But he's still having symptoms. So what's causing these symptoms? And sometimes what's causing these symptoms is just local inflammation from the muscles having been deconditioned. And, the timeline, 8 months, doesn't surprise me, because some individuals can suffer with some of these conditions for, 6 months, 12 months, even sometimes several years, if they haven't gotten into the habit of doing core strengthening and working on their posture. If they haven't gotten on the right path, the longer you are in this state where your muscles are deconditioning, the longer it's going to take you to get out of it. So I think one of the things to manage, which is sometimes very difficult because patients are not very patient. And it's understandable. If your neck hurts every day, the last thing you want to hear is, yeah, this is going to take you 6 to 12 months. But the idea is that by focusing on strengthening the muscles and chipping away a little bit at a time, you find yourself in that cycle. And for some individuals, if they've had deconditioning of their muscles for 6 months or years before, well, that's going to be a very slow recovery. And you have to be doing it, every day diligently. So the individuals who are very disciplined and diligent with their exercises, and they do a little bit at a time. And the other thing is, they don't notice that all of a sudden their neck pain is gone. What they do notice over the course of weeks and months of doing daily exercise and strengthening is they notice that their activity tolerance gets a little bit better. They start noticing, hey, you know what? I wasn't able to take a grocery bag, from the car back into the house, but now I'm able to do that. And so it's little wins like this that end up sort of compiling and making a difference. And then after a certain amount of time, and for some individuals, it's 6 to 12 months or even longer, then they start noticing, hey, you know what? My neck is a little bit more comfortable. The piece about the posture, if you think of the muscles in the back of your neck, because your center of gravity, if you look at anyone from the side, the center of gravity for your head is a little bit forward. So we all have a tendency of falling forward over the course of the day as we get tired. So the idea is that if you can bring your head back, the muscles in the back of your neck, which are the bigger muscles because they have more work to do, are not going to be under as much tension. So if you can find the right position, then the muscles can get relaxed and they don't go into spasm quite as easily. And then you can have an impact on neck pain. But this takes a long time. And for some individuals, because they've had years of bad posture, it's, easier said than done.
Mm-hmm. and likely a growing issue given everyone looking at their phones and with their
Yeah, no,
their
it's
their
terrible.
heads down all the time. Okay, thank you. Next question. If I get weekly nerve blockers and trigger point injections, sounds like they've been getting them for about 5 years and saying without x-rays, are those the same as you mentioned before? And it sounds like they're also asking whether nerve blocks, are they safe in the long run?
Right. So the nerve blocks that I was referring to are very selective, and they're mostly done for prognostication. So they're done to find out, I'm worried that this nerve is being pinched. And therefore, if I go and I put in some local and I freeze it, the nerve, the sensation of pain from that nerve should come down. That individual typically gets a response. Now, sometimes it's not just the mechanical pinching, but it's also some inflammation. So they inject not only local, but they typically inject some steroid as well to bring down the local inflammation. Now, if someone is injecting multiple trigger points, and is, sort of multiple areas, and you have to be careful because there's a number of clinics out there that, this is what they do, right? Because the setup is that the more injections you do, the more you get paid. So you just inject and boop, 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 get you out the door. So you have to kind of understand, like, obviously, if you've been doing this for 5 years and you're still requiring it, then, is it really working? You have to kind of wonder. The beauty of focusing on muscles and focusing on strengthening the muscles is that the downside is essentially there's no downside. There's no risk to it. The challenge is that it doesn't happen very quickly, and it takes a lot of time and it takes a lot of diligence to stick with the program. But the idea is that if you do that, this is what's going to help you long term, because if your muscles are nice and strong, that's what helps you sort of carry on forward. The nerve blocks are really just sort of a way of calming the nerves down so they're not overly stimulated with pain.
Okay, great, thank you. Sharon is indicating she had a concussion with whiplash injury, has facet injuries and root nerve compression at C5, C6. A neurosurgeon said I'm not yet a candidate for surgery, being treated at McMaster's pain clinic and receiving steroid injections. All my physical therapists, massage, osteo, physiotherapist, all say long-term use of steroid injections is damaging. So far, it's giving temporary relief, but she's worried about continuing with them. And asking your opinion, should I be concerned? I've heard of plasma injections. Are they safe? And should I look for another neurosurgeon assessment?
Yeah, so I don't have any experience with the plasma injection. So I don't really have anything to say about that. The role of injections, if it's combined with a strategy to strengthen the muscles, I think is a good strategy, right? So if you're in so much pain you can't do any exercise, but then you get your injections and that gives you a little bit of relief so you can get on and do the exercise and work on your posture, then you're able to fall into that cycle that you want to be in, the one where you're strengthening your muscles gradually, you're building up your core, you're working on your posture, you're increasing your tolerance, etc. And if you need a little help along the way in that cycle with some injections, I think that strategy overall is one that'll win or is beneficial, because ultimately you want to get off the injections and just be able to carry on with your life. There is the concept that this degeneration, this wear and tear with the facets and the disc, is a sort of like, it's like tires on a car. The threads kind of wear out. The more you drive your car, the more that you wear out. And some people do a lot of stop and go with their tires and a lot of, spin starts and all that stuff. And so they use their tires a little bit faster. So does that mean that everyone's destined to end up having surgery? The answer is no, because some people can slow down this process by focusing on their muscles, focusing on their posture, etc. So if this, neurosurgeon that you saw in Hamilton said you're not a candidate yet, okay, maybe they're edging their bet that at some point you will get, you may get to a stage where you do need surgery. But at this point, they don't feel that you're a candidate for surgery. So you should continue with the conservative modalities of treatment. But again, this is in the context of helping yourself get stronger and have good posture. Because if you don't do that, if all you're doing is injections and not working on your posture, not working on strengthening your muscles, then you're really just buying time.
Okay, thank you. Next question. Could your cervical discs that contact your spinal cord worsen in specific neck positions that might not be caught in an MRI where you're not moving? Also, can cervical discs touching the spinal cord cause your body to have movement disorders like FND, I'm assuming functional neurological disorder, or myoclonic jerks?
Yeah, so there's a whole literature on dynamic MRIs. So you do MRIs in flexion. It's hard to do it in extension because remember, your head and neck is being put into a relatively small bore, so it's not like you can move around. And the MRI images, the ones that I showed in my presentation, are images that require about typically 45 to 50 minutes, and you have to be very, very still. So the quality of the image is important. But you bring up a good point that there is a dynamic component to some of the issues that we were talking about, like cervical myelopathy. And so you can see someone with minimal compression, but terrible spinal cord dysfunction. And part of that can be picked up on just simple x-rays with flexion and extension. So when we do flexion extension x-rays, we see the translation of the bones, the angulation of each of the bones go beyond normal physiological movement. And so that can give us a hint as to, what may be happening. And, that may be more of a significant contributor to the clinical presentation. The second part, which is in regards to movement disorders, movement disorders is a separate topic altogether. And it's actually very challenging because there's some established diagnoses. And then there's, a number of other neurodegenerative conditions that we don't really know. Is it related to spinal cord, or is it more higher cortical functions that are involved? Taking you back to one of the slides that I showed early on with all the circuitry going from the cortex all the way down to the spinal cord and out to the muscles, you can see there's a lot of circuitry there that, we're just beginning to understand and to make sense of. And there's still some circuitry we don't understand the interplay. So, that's a maybe there may be some association, but certainly, from a surgical point of view, we just stick to the ones that we can identify on MRI and make sure that we can correct.
Okay, great. Thank you. A couple more. What causes neck instability and how can you diagnose it?
So neck instability. So first of all, you have to think of instability as not a black or white thing. It's not like you're on the bus or off the bus, but different shades of gray. So there are some conditions like trauma, for example, where there's disruption of the ligaments, disruption of the disc, fracture through the facets, etc. Those are situations where someone's neck is highly unstable. But sometimes the instability is more subtle. There's more wear and tear. And as you get older, the discs tend to dehydrate. They lose their water. And so you collapse down. And people develop more sort of rubbing of bone on bone, which leads to bone spurs forming in certain areas and causing compression. And with certain movement, this causes compression of the nerves or compression of the spinal cord, which could be referred to as neck instability. So the spectrum is very wide. And so how do you diagnose it? Well, it's a combination of different things, combination of the history, the physical examination. Some of the basic imaging can help us, like x-rays, flexion and extension x-rays, and also MRIs.
Okay, great. And one last question, it looks like. Is it possible for neck exercises to be hurting us in some way if there is something more serious going on?
Yeah. So if there is something more serious going on, the person looking after you, either the physiotherapist or the healthcare provider that's involved in your care, will need to look for some of those red flags that I talked about earlier, because those will be things that will say, maybe there's something else going on. What I've more often seen is individuals who who listen to a lecture like this one, or, they go see a physiotherapist and they're very keen and they sort of say, okay, well, if 5 minutes of exercise is good, 10 minutes must be even better. And if 10 minutes is good, 30 minutes must be awesome. And so they get in there and they start exercising. But what they do is they overdo it and they overstimulate the muscles. And then the muscles go into an inflamed status with lots of irritation. And then it goes into spasm. And those individuals go from one cycle to the next of neck pain, acute exacerbation, and ongoing, sort of discomfort, and don't really get at the true strategy, which is to strengthen the muscles and create an environment where the blood flow is more regulated and more sort of normalized. They just go from one extreme sort of pain situation to the next with muscle spasm.
Okay. Okay, now we have a couple more. If someone had chronic neck pain for over 10 years, and it sounds like this person cracked their own neck on a daily basis, what kind of problems could occur?
Yeah. So cracking your neck, just like cracking your knuckles, it really just means you're sort of stressing some of the joints. And I'm not sure I can sort of connect the cracking of the neck with your chronic neck pain. Okay, so those are sort of not necessarily sort of two things tied in together. But having chronic pain, this is important because that is a field of study in and of itself. The circuitry that we talked about in the presentation earlier on had, I didn't have enough time to get into this, but when you have and deal with chronic pain for 10 years in your case, the circuitry changes. Your wiring becomes different. Your perception of pain is different, but also there's something that happens at a fundamental molecular level, and this results in sort of another situation. And so having a simple strategy of saying, oh, I'll just do some exercise and work on your posture may not work for someone like yourself. So you need to have more of a comprehensive approach. And this is where pain clinics, and particularly chronic pain clinics, play a role, because they need to sort of help you kind of rewire your brain for not only the perception part, but try to move you into a state where the pain is a little bit more manageable and you're able to do more things with, your current pain status.
Okay, thank you. Joel has a question. I have incurred multiple concussions with whiplash over 3 years, now post-concussion syndrome. Physiotherapy and athletic therapy have led to strength gains, but after a year also still caused nerve inflammation and muscle spasms. He relies on acupuncture to deal with 10 recurring severe trigger point sites. MRI found moderate disc degeneration and white matter deterioration, but nothing that the radiologist deemed serious. Occipital nerve block steroids and 4 Botox treatments have provided a few weeks of relief at a time. I have a persistent chain reaction symptom cycle. Any recommendations for assessment or treatment?
Yeah, so I'm just reading your question here, and the radiologist's role is to interpret the images and to describe the images they see. Their role is not to deem something serious or not serious. They're just there to sort of help the clinicians, who are individuals who actually meet patients and interact with patients, sort of do their job. So I think, if you are one of those individuals who has a very low threshold for, flaring up the muscles and having the muscles go into spasm, then, finding the right sort of balance between the timing of the exercises, minimizing the trigger points, et cetera. And it sounds like a lot of these things are already happening for you. So I'm not sure I have anything else to offer here, because at the end of the day, I'm not a pain specialist. I'm the guy that kind of deals with individuals with structural lesions that need surgery. So, it sounds like you're in the right hands, and, they've got multiple modalities because they're using Botox, they're using trigger points, acupuncture. So you're obviously in a setting where multi-modalities are being brought to bear. And, the idea would be to just find the right medium between doing enough exercise to engage those muscles, but not overdoing it so that you trigger some spasms and getting yourself into trouble.
Okay, thank you very much. Well, I think that brings us almost to time. Thank you so much, Dr. Massicotte, for your presentation and answering all of those questions. It was excellent. Just a reminder to those of you watching, you will be receiving a short survey. And if you have a couple of minutes, please fill that out. And just, we always like hearing from you. And a reminder that we will be back in 2 weeks on May 14th. And Dr. Dave Gold will be with us. He's a neuropsychologist. He's going to be talking on neuropsychological assessment in persisting concussion symptoms, how brain injury affects thinking. And with that, I think we're right on time for hockey fans, either those Toronto or Boston fans out there. So hope everyone has a great evening. Take care.